Hi, welcome everyone. We're going to go ahead and get started on time because we have a lot to present to you. If anyone wants to move up, feel free. There's a lot of seats towards the front. My name is Levin. I'm a psychiatrist at UCLA CAPS.
My name is Melinda Kirschner. I'm a psychologist at UCLA CAPS.
And we're going to present today about the eating disorder treatment that we have at UCLA, and it's called Best Practices, although that's sort of a high standard to live up to. So this is what we've created over the years, and this is what we do. And we want this to be an open kind of discussion and collaboration to hear what people do on other campuses, because I think there's a lot that we can share from one another.
And we're going to be passing out some of the kind of forms and tools that we use throughout our presentation. So we'll just ask you guys to pass them around. We've created like 5 copies in an effort to be green.
Right. Okay. Here, do you want me first? Oh, sorry. Okay, so this is an overview of what we're going to present today. First, we're going to talk about our clinical services at CAPS and the scope of practice that we have. We're going to talk about our consultation model. We're going to talk about our partnership with athletics, outreach and prevention work that we do, and then we're going to talk about challenges and future considerations, things that we come up against routinely, and then I'm sure all of you do treating these on your campuses. So the second 2 areas I think will be hopefully provide rich discussion.
So in terms of the eating disorder clinical services that we provide an assessment, we provide individual therapy, psychiatry. We have 2 eating disorder groups, which is disordered eating 1 and disordered eating 2. And then we have a held urgent eating disorder slot that occurs weekly with one of the members of the eating disorder treatment team. Hope is passing around a tool that we use for our assessment. We also integrate this into our training for our interns, postdocs, and practicum students.
First, in terms of assessment, when students come to CAPS, sometimes they've self-identified right away as having an eating concern or a history of an eating disorder, and other times that's sort of discovered after maybe the initial appointment or first few appointments. So we'll kind of launch into this more official eating disorder assessment at any point. It can be done at any time, but obviously, sometimes it's helpful to know right away. And we can launch an online rating scale called the Eat 26 if we know a student has eating concerns, that can be done through PNC. All students don't get it routinely, but if someone is identified as having an eating issue, then we can use that as well.
And we try to use the Eat 26 for our groups as well. We're trying to do a pre-measure and post-measure to track outcome as well. So in terms of the groups that we offer, we thought we'd talk just a little bit about them. So Disordered Eating 1 is our sort of first group. It's an 8-session structured group, and it's for students who don't have a history of treatment, either at CAPS or in the community. So it's for students who are sort of like newly referred to eating disorder treatment when they haven't participated in a group before. And we focus on reducing symptoms through weekly goals, support from peers, psychoeducation. We help them understand some of the factors that are contributing to maintaining the eating disorder, and it's a CBT-based group. We strive to have it be an 8-session model, but sometimes, as you guys I'm sure know, with the referrals, we sort of can shift the group as needed to create sort of a 6 or 7-session group if we get started a little bit later, which can happen particularly in the fall quarter. And then Disordered Eating 2 is a continuation group, and it's for students who have sort of graduated through Disordered Eating 1, or it's for students who have a history of more intensive treatment. So they've been in group treatment before outside of CAPS or in CAPS. And so this, we basically just work on continuing to build skills, helping them to develop peer support, and basically we develop this group each quarter based on individual members that are in the group.
Okay, so scope of practice. So this is a big one. So we have limits at our center in terms of duration and intensity of how long we can see people, as we all do. And so we're a brief short-term therapy model at our counseling center. So we need to figure out what do we do with that, who do we keep, and who do we refer out, and how does that all go, and that's part of what we can talk about as far as challenges. But we've come up with some parameters to try to help guide this right at assessment. Doesn't always go perfectly, but this is our sort of some guidelines. So The people that we want to refer out or consider referring out right away if we can are people that are low weight with a low BMI. And that's because treatment for anorexia needs to be more, well, at least weekly typically, and it needs to be more intense and more than our standard 10 session. So that's how we came up with that. Daily or almost daily purging. Any history of significant current medical complications of the eating disorder. A history of recent or extensive prior eating disorder treatment. If they've been hospitalized recently, if they've been in a residential program, we know that they're going to need longer-term therapy, and the 10-session model probably won't serve them well. Or student that requires external structure to eat regularly or to get symptom reduction. And some of this language comes from the APA guidelines as far as what levels of care they recommend. And so maybe students like this, they actually haven't been to higher level of care treatment facilities, but they need something more than like every 2 to 3 week therapy sessions, especially since they don't have family support necessarily on campus.
We've also seen a number of students who are just sort of graduating from more intensive treatment, transition. They're freshmen, they're coming in, and they're just getting out of the hospital, or they're just getting out of a partial program. So we try to get those referred sort of as quickly as possible before they come in our doors.
I'm not sure if you're going to discuss this later, but how do you address issues when the student does not want to go into more intense treatment or doesn't want to go to a leadership program?
That would come under the challenges section. Yes. Yes.
Right.
Yep.
So,
and it's a big one.
Yeah, I mean, it's hard because sometimes the goal of the work at CAPS is really to get them to the next level of care, but sometimes, they get attached to us. They like us, and so they don't want to leave, and so we have that issue. Sometimes we'll also use it as a test. Like, they say, oh, I'm fine. It's really not an eating disorder, or it is, but I'm fine. And then we'll say, okay, well, let's see how it goes. Maybe you can have, 4 sessions and see how it goes. Are you able to make the gains in terms of your weight or a reduction in symptoms?
Meeting that, but part of the treatment plan will just incorporate working them to hopefully get to that.
Yes, and I would say that happens more often than they immediately go. Like, usually they don't immediately go unless they're socialized to that, from their work before arriving on campus. So.
And we've had some success if the family is involved. And so we've had a couple, I think recently, mom calls clinical coordinator and is wanting to try to sort of establish the team outside of CAPS, aware that CAPS has limitations. That's our highest success kind of category. But I think this is a huge challenge that we really struggle with.
Oh, we should.
I'm going to pass around the brief screening guidelines and let me.
Okay.
There you go.
So at our CAPS, we have brief screen, which is our triage system. I don't know if all campuses have it, but probably not. But so all students that are presenting for services have a brief triage appointment, and from there it's determined how soon are they going to get their initial intake with a therapist. And so we've tried to, this is a newer endeavor, but we've tried to come up with just, again, some kind of like bullet points, guidelines to try to help people because it can be overwhelming, and we want to make sure that the more serious cases aren't getting missed. What we found is we all know the students that are high risk in other ways, in the aggression, suicidality, psychotic. Everyone can recognize that they need urgent attention or emergent attention, but occasionally a student with an eating disorder was getting missed because they didn't identify the level of acuity because they think they're fine, and that's really part of the eating disorder is the denial of symptoms. They're egocentric. There's a tremendous ambivalence about getting better, and so students sort of aren't necessarily presenting with the urgency. So we've tried to create some guidelines around who we would like to be seen right away versus can wait a little bit. And typically, we have 3 categories of urgency. So a routine referral, and that's basically like next available, and those are typically every 2 to 3, depending on when in the academic year, 2 to 3 weeks. Is that good? Okay. What?
It can be longer.
2 to 4 weeks they would get seen. And so those are people with body image concerns, binge eating, mild restriction or dieting, infrequent purging, like less than weekly, or if they already have a whole team in place and they're just coming in for group. That happens sometimes. Okay, so the urgent referral will be, they get seen within 7 days. And so these are people that have low weight, that have significant restriction, even though maybe their weight hasn't dropped below where so their BMI is still normal or even could be high, but they're restricting a lot, because we know that group, they're really still at high risk for medical complications. So it doesn't matter if even if they haven't shown it on the scale yet, they're still at high risk for medical complications. So regular purging. So we said weekly or any increase, any kind of a signal that they might be getting worse. History of any significant medical complications. So irregular menses, heart problems, electrolyte abnormalities, osteoporosis, hair loss, dental issues, or fainting. So again, we want to, if there's any signal, we're kind of trying to get our, just like a sort of cast a wide net for any clue that they might be more serious than they're actually indicating. Or a history of any kind of eating disorder treatment or a more extensive kind of treatment.
This has also been really helpful kind of catching some of the students who are minimizing symptoms, because sometimes students will say I have a history of anorexia and now I'm recovered, and then those students were getting missed because they still actually had many of the very severe symptoms. So for our brief screening team, this has been a really useful, I think, piece, the urgent referral.
You're talking about a triage appointment, right?
Yeah.
And so does everyone get asked these questions, or are these targeted to something you already know about the student you're triaging?
Everyone gets asked a question about eating. These are going to be more specific questions if someone is indicating that they have a history or some current symptoms of an eating disorder.
Okay, so then our emergent categories within 24 hours. So these are people very underweight that are fasting, if there is a concern for overt medical symptoms. So not that we have to do a medical assessment at the counseling center, but if it's pretty obvious, like they're having chest pain or they're fainting all the time, then those people should be referred to ASH is our health center right away. And obviously if there's other kind of significant risk issues that otherwise would warrant an emergency evaluation, then that would apply to these students as well.
Okay, so we're going to talk next a little bit about the eating disorder treatment team, and Hope's going to pass around a sample letter to a student of concern, and also our eating disorder treatment recommendation form. This is often something that we use in consultation with our staff. So one of the things that we sort of realized in terms of care at UCLA is we're generalist practice there, and I think different clinicians have different levels of comfort working with treating eating disorders. Many people don't have specialized training, and it's a really complicated group of people. And so what we did is create a team around clinicians who have training and experience working with students with eating disorders or working in that population. And I think that's been really useful because the team has been able to take on a number of referrals, but also consult with our broader staff as they grow more comfortable treating these students. Obviously, there's also a lot of medical complications that go along with the treatment and the need to work with multidisciplinary treatment team. And so we found that having a few staff sort of named as on this team has been helpful in terms of our collaboration with the Student Health Center and kind of working with our colleagues there to facilitate a improved working relationship. It's also been helpful in terms of efficiency of referrals. We can get students in to see a member of the eating disorder treatment team, and they kind of know what to do instead of having a lot of consultation for staff who maybe don't have as much training working with this population. So that's sort of our rationale. And then in terms of the function of the team, we take on referrals, we consult with the broader staff, both at CAPS and also in our Student Health Center, and then we do more specialized assessment, referral, and treatment. And then we all participate in the training program as well. So the staff, we have Hope is our lead psychiatrist, I'm the lead psychologist, and then Dr. Katie Jekyll and Dr. Kathleen Lambert are two other psychologists that are on the team. So in terms of roles, Hope coordinates the partnership with our Student Health Center, which his name is ASH. She participates in the training program, coordinates the eating disorder partnership meeting, which she'll talk a little bit about in a few minutes, and then consults with our staff. And I coordinate partnership with athletics. I take on urgent eating disorder intakes. I coordinate groups and our group referrals. And then I participate in the training program, and I'm also available for consultation for our staff. And then Dr. Lambert and Jekyll also take on referrals and participate in the training program, and they also participate in our monthly consultation meeting, and they rotate our group leadership. We try to keep our groups running by those members of our staff who have more specialized treatment, so that they can, so that we can provide that treatment, but also train our trainees, if that makes sense. Okay.
So, because eating disorders have so many medical complications, we really try to take the perspective that it's a multidisciplinary approach with primary care and also with nutrition in treating these students. So these are the students that we are keeping, that we feel like are the right level, that we can work with them and help them. So our student health center is near our counseling center, but we're not in the same building. We're like kind of on opposite sides of this huge gym building, and our staffs are completely separate. So a lot of campuses have like psychiatrists or housed in primary care, or some psychiatrists are, or we're totally separate entities, and it's created a lot of challenges, just like there are when you're working, across different centers, different disciplines. We have, mental health and primary care. We have really different perspectives often on things, and so over the years, we've had a lot of challenges because we view this as sort of, it's like part of the treatment is to get the medical care done. But sometimes we would get pushback from the medical side, like, oh, this is like a mental health problem, like this isn't our thing. Or we would get it like, okay, we'll do like a physical on them, and then like check, the box is checked, and then it's like CAPS problem. And so and obviously like that really depends on like it's all about the people, so it depends on who's on the other side of that. But we've made some inroads in some collaboration. And I think what we've fought for them to identify practitioners that are going to specialize or have more expertise in eating disorders, and that's been met with a lot of resistance because they also have like a primary care generalist model. But we've made some inroads. So one thing is that we had a CAPS eating disorder treatment manual. It's being passed around, and a couple years ago, the medical director, the clinical director over there, wanted to kind of be part of the endeavor with us. So that was like pretty huge that they identified that would be helpful for them. So that we sort of changed ours a little bit and added the medical piece and the nutrition piece. So you can see in there that there's recommendations for different students, like how often they should see primary care, what primary care should do, exercise recommendations for students. So that's been great. Also, they have at some points had a dietitian on their staff, and at others they haven't. For the past few years, they have had a dietitian. So the dietitian is housed under the student health center. So that's also been a really great development. Now, she is not specialized in eating disorders. She's basically the only clinical dietitian for the whole campus. There's another dietitian who does education, but she's the only one that does clinical. So she's seeing everything. She's seeing people with diabetes. She's seeing people with kidney disease or what have you. So she's needed some education about eating disorders, and so that's worked out well. So we have that. And the other thing that we've been able to do is that we'll talk about a little bit later, but we have a monthly multidisciplinary consultation meeting. And so so the dietitian comes, and they've also identified one primary care doctor who comes as well. So that was like huge that they were able to say, okay, this person is allowed to come. And she also went to this conference that we went to, and so she's getting more sort of exposure to the eating disorder treatment. So that's been really good.
And she kind of acts as a liaison in some ways when we have concerns with their system or we're consulting about a particular case. She can see the chart and bring that information and sort of work as a liaison between our department and hers. It's been really helpful.
Yeah. So when students present when they have a diagnosis of an eating disorder, we do ask for all of them to be referred to the health center for a medical evaluation. And that is both to see where they are in terms of medical risk as far as what level of care they need, and also to provide some psychoeducation, ideally, so that the primary care doctor can help talk about some of the dangers of what the student is actually doing. So all the therapists will refer the students to the health center. Now, sometimes that goes, it's straightforward, no big deal. The therapist is supposed to send a message through PNC to the primary care doctor to give them a heads up. But other times it's like a ton of work and a ton of therapeutic engagement to actually get the student to go over. There's just like a lot of resistance for many reasons. And so we feel like the communication is really important for the initial appointment, because if the student shows up and the primary care doctor has no idea or is insensitive to it, that could be a problem. Or sometimes they'll show up and they'll just say, CAPS referred me, and there's no indication what it's for. Like if somehow the primary care doctor didn't get that message, then that's like sort of a disaster for us. It's not a real disaster, but it's a problem because it's like they finally made it over and then the eating disorder wasn't addressed. So that's an area where we're always trying to kind of tighten that up.
And one of the things that's been really useful is just having just a shared name. So the fact that CAPS and ASH both call it an eating disorder medical assessment has been really useful. We refer them for that, and we use that name in our IM, or our secure message to the clinician over there. And also we encourage our staff to sort of name the recent symptoms and maybe history that we're concerned about, so that even if the student shows up and doesn't share a lot of information, the clinician has a heads up around what's going on. Because as Hope is saying, that's been a problem in terms of treatment, because they sort of come back to us and say, like, Ash said everything was fine, and then when we say, like, what did you talk about, they like didn't even disclose that they have an eating disorder. So that's been obviously a huge challenge. The other thing that we've done more recently is we've made this a requirement for our groups. So students are motivated to participate in groups, which has been great. And so one of the things that we felt like was important is to have a requirement that in order to participate in a group, you have to have had a recent medical appointment. And that has been really useful, I think, in working with our clinicians as well, for those clinicians who've had a hard time getting some students over, to sort of say this is a barrier in terms of joining our group.
Mm-hmm. One thing that we would always like back from the primary care, which we don't always get, is the frequency with which they want to see them. Because again, we're trying to give this message that we're co-managing the student together, but oftentimes there's no like indication of that. So that's sort of a challenge or area for futures, that to kind of again tighten that up. It's like, no, do you want to see them again in a month or so forth? And in the manual, there are specific guidelines for primary care about how often they're supposed to be seeing them. It doesn't always happen, but that's kind of what we work towards. There's one more thing I was going to say. It's okay.
Also, I guess one of the other things, sometimes we'll have students over there who are just getting like weight and vitals, sometimes weekly, and they can set that up with ASH without seeing a primary care physician, and oftentimes the dietitian will do that. And we try to do some psychoed with students who might need or benefit from blind weighing, and that has been historically a bit of a challenge. So we're trying to also tighten up that as well, so that like the nursing staff understands what that means, and students can get that if they need it.
And I found that takes the primary care doctors kind of like calm down. Like when they think that we want them to see someone weekly, they sometimes get like edgy about that's too often. But if we say, oh, they could just see a medical assistant to get weight and vitals, and that they like that, and so then they'll see it and they'll be able to sign off of it and intervene if there's a problem. But they like that. Oh yeah.
I don't know if you said this because I was reading the letters and all this great stuff. But do you guys require a release of information to your medical from your eating disorder student before you send an IM or a secure message?
We don't, because at our center that's all considered one HIPAA entity, so we don't have to do that.
So if you say you need this treatment, so we're recommending medical, then you'll just go ahead and send to their primary, but they may or may not follow through with making that appointment.
Correct, right. But in our system, there's always identified who their primary care provider is, like in P&C, so we have that. And the same thing is if they have private insurance and they already have a primary care doctor in the community, then obviously in that case we'll need the release, but we'll make the same recommendation. Sometimes, just the way our system works, it's actually easy, even if they have an outside private insurance, but their doctor's in a different city, we'll still recommend that they go through ASH, just because it's easier to coordinate care and it's right there, and the fees are reasonable. One thing that I have also noticed just in this process, when we were creating the manual and just working case by case, the primary care doctors, they really, maybe one or two here or there, like have more experience, but they really don't feel equipped to sort of manage like the overall picture with these students. And I think a lot of the anxiety that they have comes from the idea like they're supposed to sort of know what to do or do everything. So one message we try to impart is that they have to do like their piece of it and really well and like with some thoughtfulness about how often they want to see them and so forth. But we'll be in charge of sort of overall managing the case and figuring out what level of care that person needs. And like we are the ones that can help figure out what programs they need to go to, and we can call their parents. I mean, they can too, but like I think they felt like they were being dumped on a lot or things like that. And I know there's a lot of, you know, territorial kind of issues, and that's how it is, but I think that helped as well. Like, we want you to deal with this part of it, but you don't have to. So your SHIP will cover outside treatment programs?
Yes, actually, we do, and I actually have a student that took a medical leave last semester and we benefited, came back, and she's now a healthy lady, just going back to school, so, yeah.
That's great.
Our insurance coordinator really sat down with her and said, this is what your options are. And these programs are thousands and thousands and thousands of dollars, and so the usage to cover it, you know, just reminding this is a first generation student whose family is not healthy, and it was like, you can make this free, like $500 as a deductible essentially, and she needed to work with the program, and so kind of identifying just those resources might also be an option for the students so they know what they can.
Great. Any other questions or last thoughts? No? Okay. Okay, thanks for coming.
Sorry, we're over.